Good morning, everyone. Thank you so much for that warm introduction, Dr. Floyd, and for the invitation to speak today. I'm honored to be here with you today, especially to celebrate Hispanic or Latino Heritage Month. As she mentioned, Dr. Baraka and Floyd mentioned, I did medical school here a couple of years ago. So it's been a while since I've been back, and it's wonderful to see all these beautiful new spaces. So I'm excited to explore those later. This morning, I'm going to talk about a primary care collaboration between WIC and the healthcare system to increase enrollment and to improve communication. And although I'll focus on primary care setting because that is where I work, this work can be replicated in all areas of the health system, including in the newborn nursery, the NICU, inpatient wards, as well as subspecialty clinics. So be thinking of that as you're potentially considering replicating some of this work. First, I have no disclosures. And for my educational goals, by the end of this talk, I hope that you will be able to identify the evidence-based health benefits of WIC, propose some strategies for increasing referrals from primary care or other clinical settings, and suggest some strategies for improving communication between the healthcare system and WIC. So although this will likely be a review for all of you, since we are pediatricians, I wanted to start off with providing a little bit of background about WIC. So WIC is a nutrition program that is federally funded by the USDA, and it is administered at the state level. WIC provides low income and nutritionally at-risk pregnant and postpartum individuals, as well as infants and children under the age of 5 with nutrition, nutritious foods, nutrition education, breastfeeding support, and referrals to healthcare. Eligibility criteria include being at less than the 185th percentile of the federal poverty level, which for a family of 4 is about less than $51,000 a year. And those who qualify for Medicaid automatically qualify for WIC. In the fiscal year of 2022, WIC served about 6.2 million participants monthly, including an estimated 39% of all infants across the United States. And throughout its 32-year history, WIC has received strong bipartisan support. Just a little bit on the background of the waivers that occurred during the COVID-19 pandemic. There were many that increased access to WIC, but I just wanted to discuss the main 3, which have a little bit of relevance to the projects I'm going to talk about today. So the first was the physical presence waiver, which allowed participants to enroll or re-enroll in WIC without having to visit the clinic in person. It also meant that it waived certain medical tests, such as anthropometric and blood work measurements. The remote benefits issuance allowed WIC agencies to issue benefits remotely so that participants didn't need to go in person to obtain those benefits. And then lastly, the medical documentation waiver allowed WIC agencies to extend existing benefits to for more than 2 months to those who had a qualifying medical condition. So typically that meant it wasn't necessary to receive a prescription from a medical health or a medical provider for a special formula, for example. So there are numerous evidence-based benefits that are across the literature. I'm going to just name a few of those that are relevant to us today. So WIC does reduce the prevalence of food insecurity by about 20%. It also improves the overall dietary quality, including the consumption of fruits, vegetables, whole grains, and lower fat milk. It's also associated with increases in breastfeeding initiation. Overweight and obesity decreased moderately among young children, and it's also associated with improved birth outcomes, including lower rates of preterm birth, low birth weight, perinatal death, and infant mortality. And actually, the earlier we enroll individuals during pregnancy, ideally within the first trimester, the more benefit we see. So even a push to enrolling earlier in life. So it's also associated with stronger cognitive development at age 2 and better performance in reading in elementary school. And so given those benefits in educational attainment, it's associated with improved economic outcomes later in life and really can improve intergenerational poverty. So lots of great, lovely things about WIC. So although WIC does improve health outcomes, many WIC eligible children are not participating. So for example, based on the most recent national data that we have from the USDA, in 2020, you can see in the gray bars, only 82% of infants on the left side of the screen who were eligible for WIC were participating. And that percentage declined to 24% on the right side of the screen to children who were 4 years of age. And then compared to coverage rates in 2019, which are in the blue bars, rates declined in 2020 for all age groups. And this has been a trend since 2007 of declining participation for quite a while. So the American Academy of Pediatrics, the Food Research and Action Center, the National WIC Association, and even the California WIC Association all recommend a better linkage between WIC and the healthcare system to better support and serve our families. This schematic is actually from a publication from the California WIC Association, which is calling to action for improved linkages between WIC and the healthcare system. And so you can see there are many different areas that they highlight in this slide, but you can see that health features prominently in most of these connections. Furthermore, even despite these recommendations that WIC and healthcare providers should really coordinate care, traditionally WIC and healthcare providers provide care in a silo. So for existing WIC clients and patients, communication between WIC and the healthcare system really has required that families serve as that intermediary. And if you are like me in the primary care system, you've probably tried to call WIC many times and vice versa, they've tried to call you many times. It can often be difficult, or you're relying on the family to tell you what WIC said and vice versa. So that can often lead to a lot of frustration. It can lead to some confusion, even many phone calls, additional visits, and then duplication of data. So for example, WIC getting a hemoglobin, and we also get hemoglobins. And then for new clients, referrals from the healthcare system can also require multiple steps, which leads to increased work on all parts and access to receiving services. So first, I'm going to talk about a quality improvement project that was really resident led. So if you're a resident here, consider a potential project. So as part of our advocacy curriculum, all residents visit our local county's health department, which is where WIC is. They speak with the WIC director, and they speak with the lactation specialist, so they learn about all of WIC's benefits, but they also follow clients through a visit so they can really get a sense of what their patients are experiencing outside of the walls of the clinic. One of our residents, who was highly motivated, he learned about the declining enrollments over time from 2014 to 2019, which is what this slide shows, over time, that declining participation. And he was really interested because during this time, it was in the context of public charge, and we serve a large Hispanic population, and we were worried about the potential chilling effect of public charge with our population contributing to this decline. And so that was really his impetus. But he also wanted to learn more about why eligible families were not participating in such a lovely program. As you can see, I'm very biased. And he wanted to develop an intervention within the healthcare system that could increase this connection with WIC. So we developed a project with the primary aim of increasing WIC enrollment among families presenting to our primary care clinic. And again, this doesn't have to be the primary care clinic. It can be really any part within the health system. Our primary drivers were in the middle column, and I'll just briefly cover those, which are identifying WIC non-participants and assessing barriers to participation, improving counseling of families about WIC, improving knowledge among providers, and then facilitating access to WIC referrals. On the far right, you can see our action items, which I'm going to go through in subsequent slides. So just for a background of kind of where we live and work. Atrium Health Wake Forest Baptist is a large health system in the Piedmont area of North Carolina. We use Epic, which I think you also use here as our EHR. And we conducted this project at one academic safety net clinic that serves about 15,000 visits per year. 92% of our patients have Medicaid, 65% self-identify as Hispanic, and about 45% speak Spanish. And depending on the time of year, 15 to 20% of our population have food insecurity. We are very fortunate at our clinic, which I realize may not be the case at many others, but we do have a co-located WIC office within our clinic. We screen for food insecurity for every patient at every visit. We have an on-site food pantry, and we also have a bilingual care navigator who only assists patients with any food-related concern. Our cohort was all children under the age of 5 years presenting for a well visit, and then all physicians at our clinic. So for our first Plan Do study ACT cycle, we focused on provider education, WIC screening, counseling, and referral. So we assessed providers for their baseline and their perceived knowledge prior to the intervention via questionnaire. And then shortly after, we provided education about the study interventions through didactics. We also disseminated an email, and we put up information in the provider workrooms. And then we reassessed their perceived and actual knowledge after implementation of all of the PDSA cycles 10 months later. As I mentioned, we already screened for all of the social drivers of health, but we weren't screening for WIC participation. So we started screening caregiver reports of WIC enrollment and WIC interest, and we embedded that into the electronic health record for our note templates to guide our visit for all children under the age of 5. We also implemented a bilingual 3-question item where we provided all families the survey. We basically asked them what were their barriers to participation, were they interested in a referral, and did they give us consent to share their information with WIC. Families completed this voluntarily at each visit. We collected all of that information afterwards. And then for those who indicated that they were interested in a referral, we compiled a list. And again, luckily with our clinic downstairs, we were able to just hand that list off to WIC, who then facilitated enrollment. And that was with the care navigator. So for our second PDSA cycle, we mostly focused again on education, including interactive didactic sessions. We also did additional emails to try to reach more providers and really reinforce the importance of counseling. For our third PDSA cycle, we embedded our WIC referrals within the EHR. So we modified our note template, again, replacing that paper questionnaire. We added those questions to our note templates, and we asked non-participants about their interest in a referral and their consent for a referral. And if they wanted a referral, then a referral was automatically sent to our care navigators in Basket and Epic, which served as both documentation and an easier way to kind of compile that list of names. So it replaced the paper, but we were still hand delivering that list of names to WIC, who could then follow up. So to improve provider counseling, we embedded a prompt in the note as well to ask about WIC counseling. So our main outcome was the monthly count of new WIC enrollments at our co-located WIC office. We thought that new enrollments would be more sensitive to our interventions rather than just total participation, which included those who were already enrolled and maybe not affected by our intervention. And then our de-identified data were provided by our local WIC office. We tracked 3 clinic-based measures, which were WIC screening percentage, counseling percentage, and referral count. And all screening, counseling, and referral data were EHR derived. And unfortunately, this was new, so we didn't have any baseline or comparison data for that. A fourth measure was provider knowledge, as I mentioned, and that included confidence and counseling frequency at baseline and then 10 months later. We plotted our new enrollment data on a C-type statistical process control chart, and provided perception of WIC knowledge and counseling before and after were compared using a Fisher's exact test, and then provider knowledge test scores were compared with a 2-sample t-test. We also looked at secondary analyses of those barriers to WIC participation. So we extracted the data from those surveys, and then we extracted data from the EHR for the demographics. And then we tested for predictors of WIC participation based on the variables that I list here on the slide that we hypothesized to have some association with WIC participation. And then predictors were examined using univariable and multivariable logistic analysis. And then all variables were used to control each other, since we thought that they all affected WIC participation. So what did we find? So this is our control chart, and this is our main outcome measure. Starts here on the bottom, January 19, and goes all the way through December 2021 to get a spectrum of where we were at. So our study revealed a pattern of improved WIC enrollments with sustained special cause variation after the project intervention. So you can see PDSA-1 is up here, PDSA-2 and PDSA-3. And the center line in light blue right here was fixed prior to the intervention phase where we thought the system was stable. And then special cause variation corresponding to the interventions was noted in August 2020. And new enrollments increased by about 43% over the study period. We had process measures that we tracked, and we had 4,740 eligible well-child counters. 78% of those screened reported that they were already participating in WIC. And so our WIC screening, as you can see, remained relatively stable, pretty much above the median, and that was likely because we embedded it into the chart, and so it was pretty stable after that. We had 197 of 248 WIC interested non-participants who were counseled, which is about 79%. And again, we didn't show a sustained change after the interventions. 386 families consented to a referral. And again, this was unsustained. We had a little bit of a dip in June 2021 and September 2021 that increased by the end of December 2021. So for provider perceived and actual knowledge, we had 37 and 21 complete the baseline and follow-up surveys, and both perceived and actual WIC knowledge significantly improved from baseline, as well as providers reported significant improvement in WIC counseling confidence and frequency. For WIC barriers to WIC participation, we had about 1,800 total eligible well-child counters. We eliminated duplicates, so that was about 500, and then we had about 130 who didn't have data. So that left us with about 1,171. So you can see predominantly, or just a little bit more, were male from that cohort. Most were under the age of 1. About 55% identified as Hispanic and 26% as Black. We had 60% speak English and 38% speak Spanish, and again, 92% had Medicaid and 6% none, 2% private. At that time, we had about 12% who reported food insecurity, and 74% of that cohort identified as already participating in WIC, with 26% who were not. The main barriers to WIC participation, we had 190 who filled out that survey, and the 3 main barriers were access problems, which included time, forgot, problems with applying, problems using the card at stores and transportation. There was also a WIC knowledge gap that was about 31%. That included not knowing how to apply, not knowing eligibility, or not knowing about WIC, or don't need WIC. There was also a fear of COVID, and then what we thought was our initial impetus to really look at this data about potential for public charge. Really only about 8% of those patients reported that they were worried about using governmental benefits, and they were all Hispanic, and that was about 14.7% of our Hispanic patients. For predictors of WIC participation, we had some significant associations with age as well as insurance status. As the child's age increased, the odds of WIC participation decreased, which again is pretty similar to what we've seen nationally. Privately insured or uninsured families had lower odds of participation. And then race and ethnicity and growth percentiles had significant associations with WIC participation, but that didn't persist after controlling for other variables. And then as the weight for length percentiles increased, the odds of participation in WIC decreased. And self-reported food insecurity and preferred language had no association with WIC participation. So our findings for this QI project, we indicated a measurable and sustainable benefit of a relatively simple screening, education, and referral strategy for WIC enrollment through compiling this list that I mentioned that we would then hand deliver to WIC. We demonstrated feasibility of incorporating these interventions into workflow. We also demonstrated a clear understanding of barriers to WIC participation, identifying that WIC knowledge and access problems, which are potentially modifiable. And then we also identified several predictors which were consistent with the literature. So following that study, we we wanted to not just improve our WIC enrollments, but we really wanted to improve that communication piece. Again, recognizing that the back and forth calls can really be time consuming for both parties. And so that led us to developing this mixed method study that was funded by the Healthy Eating Research. So we wanted to evaluate the effectiveness of EHR embedded screening and referrals on WIC enrollment. We wanted to get a caregiver perspective on what their thoughts were about communication between WIC and healthcare providers. And then we wanted to explore perceptions of healthcare providers and WIC providers about this EHR program. So we also had the fortune of having this long-standing memorandum of understanding and data use sharing agreement with our local health department, because we have a long history of having this shared population. So that was all in place prior to this project. So we've had that history of sharing data. So we were able to provide WIC with our access to our EHR through what's called WIC Health Link, which is otherwise known as Epic Care Link. So you likely have a form of that, and you may call it something else here, but that provides secure, individual, read-only access via the internet to our electronic health record. And so for our health system, I think you can decide what access you give to your community partners. We decided as a health system to give WIC full access of the chart. That means that they can access our patients, the notes from the healthcare system, their growth chart, lab data, demographic data, as well as contact information. They can also see prescriptions from providers as well, and they're also able to send secure messages to healthcare providers through their in-basket, and then vice versa. So although the goal is really cross-talk between the two systems, this project is really just focused on the healthcare information going directly to WIC. And so that's a start. I think ideally it would be a two-way communication. And so with this project, though, we don't have access to those WIC records, although they have access to ours. But we are able to send messages back and forth to WIC through the EHR, and also send prescriptions. So now that WIC had access to our EHR, we tried to get a little bit more efficient. We worked on educating our WIC providers on how to use the EHR through this WIC Health Link, how to use the in-basket. We also established regular ways to check the in-basket. So they have their own system that they use every single day, and this is an extra system that they have to access in order to review charts and check their in-basket. So we established processes to be able to do that. And then we worked with our clinics on the importance of screening, how to screen, and how to educate on WIC. We also had multiple stakeholder meetings about putting this in the chart. And I can talk about those at length if you have interest, but we settled on building screening within the EHR specifically for, we have some patients that have, or some clinics that have a different payer mix. So some have 50% Medicaid, some have 75% Medicaid, and many providers did not want screening for every single patient. So we settled on screening just for children under the age of 5 every 180 days, who had Medicaid or were uninsured, lived in one of the 3 counties that we had relationships with the WIC agencies. And then we expanded the referral that I mentioned from the initial project from 1 clinic to 7 clinics throughout the health system, including some family medicine clinics. The academic clinic that I mentioned earlier, we continued the same process of screening and referral using the embedded note, using the note system. But for the 7 other clinics, we implemented a screening and referral as a best practice advisory. You probably are familiar with those best practice advisories, and you probably have gotten them popped up before. But essentially, those are electronic alerts that are received by clinicians who are working within the EHR, and they're designed to influence clinical actions and clinical processes. And so you may have gotten a pop-up that this patient is due for the flu shot. Would you like to order it? Yes or no? That's an example of a best practice advisory. So the ultimate goal of this BPA was to screen patients for WIC in interest and participation, and then send that referral through that BPA. At those 7 clinics that I mentioned, we implemented a BPA to pop up for the medical assistant when they were rooming the patient during the rooming process, but it only popped up once. So as you can see from the flow chart, the screening process started with the question, does your child currently use WIC or SNAP programs? And then we preface that SNAP is formerly known as food stamps. attempts. The answer choices are in the second column, which were WIC and SNAP, WIC only, SNAP only, none currently, not sure, or did not ask. And so for those who indicated that they were only participating in SNAP, none, or unsure, we additional question popped up that asked them with the preface that WIC is a free program through the health department that provides food and nutrition support. And then we asked them if their child is participating or using WIC. And if they were not, were they interested in, did they approve contact for WIC? So could we send their information? That really served as documentation of a verbal affirmation, but for the family for us to share their contact information. So then this WIC referral was then sent to the WIC in basket, who was then checked weekly, and then they called the family and they either enrolled over the phone because of this physical presence waiver. They could really just enroll on the same day, or depending on their workflow, sometimes they set up appointments a little bit later. As you can see down here at the bottom, because it only popped up once, depending on where they were in their clinical counter, the MA could hit did not ask, and that would dismiss the screening. And although this wasn't part of the study, we didn't actually look at outcomes related to this, but this is something that we did as part of the study, which was we embedded the WIC prescription, which is originally on paper. We heard from our WIC colleagues that we as medical providers often don't write the right answers or what they're looking for, what they need for the documentation, and they often find that they can't read our writing. So we put this in our communication tab for this prescription, and as you can see, we provided answer choices based on what WIC said is helpful for them. And that included the type of formula or product. We also added a link to what products are available, the amount, special instructions, and then if they didn't want any specific part of the WIC package. And then this was able to be faxed directly to the WIC clinic through the EHR. And we got feedback anecdotally that they really appreciated it because they were correct and they could read it, and it really eliminated that back and forth communication. So in summary for the methods, we provided, after providing WIC EHR access, we screened for the Federal Nutrition Program participation in 8 clinics. We referred to WIC via the EHR, and we verified through weekly calls, because remember, we don't have access to WIC, so we literally had to talk on the phone every week to determine the outcome and disposition of each referral. We surveyed 100 families about their perceptions regarding WIC, and then we conducted interviews with 20 providers, WIC providers, medical assistants, nurses, and physicians, and analyzed with thematic analysis. So the results of our screening, we had about 3,675 unique children who were screened for the Federal Nutrition Program participation. And as you can see, the most common result was 36% of those were not asked by the MA, so they clicked the dismiss button, followed by 28% who were already participating in WIC only, 17% were both, 9% were none, 7% weren't sure, and 3% SNAP only. So you can see for that, 19% were the cohort that we ultimately were able to ask about a referral. We ultimately referred 358 individuals to WIC who received about 99% of those. The disposition for about 59%, we newly enrolled them or re-enrolled them because of the referral. And unfortunately, we had a big number, about 32%, that we weren't able to contact. So we called families at least 3 times in order to try to enroll them, or they had an appointment scheduled and they didn't show to the appointment. About 18 or 5% of those were already participating, so they didn't realize. I failed to say that we did do a validation between these questions. So we did 100 patients who said they were participating or not, and we verified with WIC whether that was correct, and about 99% were correct. So we felt that those questions were pretty stable. But we did have 5% who we had 3% who were already enrolled, and 5% who ultimately said yes in the beginning, but then they weren't interested when they were called. We surveyed again 100 families. 93% were mothers about the mean age of 30. 33% were Black, 19% white, and other usually corresponds in our health system through research projects that we've done fairly closely with the Hispanic. Many Hispanic individuals don't identify with any of those races, so they say other. It's not perfect, but 53% identified as Hispanic and 45% as non-Hispanic. Mean age of child was 3.5. At that, in that cohort, 35% reported food insecurity and 14% transportation insecurity. We asked caregivers how comfortable they were with WIC having access to their child's chart, and 75% in light blue were very comfortable, and 16% in gray were somewhat comfortable. 6% were not at all comfortable, and 3% said, I don't know, in dark blue. So about 91% were overall very or somewhat comfortable. When asked the level of comfort with their child's healthcare provider communicating with WIC about their child, 79% said they were overall comfortable in blue, 17% were overall uncomfortable in gray, and then 2% were neither, and 2% were I don't know. These are the demographics of who we interviewed. So predominantly 95% female, predominantly white, 85%, predominantly non-Hispanic, 30% were, about 60% did not speak another language other than English, 35% spoke Spanish. We had a range of professional degrees. And then we interviewed 8 WIC providers, 7 physicians, 5 MAs or RNs, and again, a range of experience. So the main themes we found from our qualitative analysis was that healthcare professionals had a positive view of WIC, but communication was limited prior to WIC having EHR access. Health professionals favored WIC screening using the EHR, but the workflow challenges existed. WIC providers and healthcare providers recommended that WIC have EHR access, and that an EHR access between WIC and the healthcare system can really streamline referrals and enrollment in WIC. And I will provide some quotes. So for the first theme, that healthcare professionals had a positive view of WIC, but communication was limited prior to EHR access. One WIC provider said the difficulty was having the consistency of having to leave multiple messages of what we needed, and then to have the prescription sent incorrectly, and then to have to reach back out. Unfortunately, this communication delayed the corrected prescription, which meant it delayed the services that we could provide for that customer. One pediatrician said, overall, WIC is an excellent program. It offers nutritional advice to families who otherwise do not have access to such advice. It provides formulas to moms who are not breastfeeding and lactation consultant support for breastfeeding mothers. So I think very highly of the program. For theme 2, healthcare professionals favored WIC screening using the EHR, but workflow challenges existed. One pediatrician said, time is sometimes a barrier. It is part of our standardized workflow, so I think it's missed less. But sometimes if it's just a quick visit and the patient, or if the patient was late, I could see how time might be a barrier. One MA said, a lot of people don't feel comfortable with answering questions like that if they are getting assistance. So I put it into my own words to make them feel comfortable with answering the question. For theme 3, WIC providers and healthcare professionals recommend that WIC have EHR access. One WIC provider said, because of COVID, we don't have measurements for the kids since they were born literally. So sometimes having the real data because the parent can't recall exact measurements is very beneficial because we can access growth data. One pediatrician said, I think it really helps with the referral process. I think there's less likelihood of it to get dropped, and hopefully there's a higher percentage of referrals made that actually get followed through with, and families are able to access this service. And then lastly, for theme 3, an EHR connection between WIC and the healthcare systems can help streamline referrals and enrollment and improve in communication. One WIC supervisor said, it allows me to be able to see the last visit with the provider in terms of there was something that the provider discussed with the family that I'm able to say, share with me what the provider's thoughts were at the last visit, already knowing that what those thoughts were, and to be able to support the provider, what the provider had said. And we are on the same page on the education we are providing with the family, which I think is the ideal situation that we want across the board. And then and the pediatrician said, this EHR referral workflow is just so streamlined. It just takes a lot of extraneous work out of our day, and it's very much appreciated. So we found that EHR-based WIC referrals may offer an innovative method for increasing WIC enrollment. Overall, families seem to be comfortable with WIC EHR access and WIC discussions with their child's healthcare provider. WIC and healthcare providers overall did have positive feedback, but about referrals and opportunities to communicate, and they did provide some suggestions as well. Although future studies will be needed to evaluate the effectiveness of EHR-based referrals in other clinical settings and to really explore family feedback on what are the reasons why some of that discomfort may exist. So future avenues for this project. So we have additional analyses that we would like to conduct of the current project. We just received a full data set, so we're trying to eliminate duplicates and reanalyze. We do have funding from RWJ to expand to 3 obstetric clinics within our health system, again, recognizing that enrolling pregnant individuals as early as possible is really the goal to improve birth outcomes, which we know then affect later life outcomes. We've also embedded a WIC nutritionist in our newborn nursery to help facilitate enrollment early in life. And then we are connected with Atrium Health. We will be expanding to 1 pediatric clinic, 1 obstetric clinic in the Charlotte area. We are in Winston-Salem. And then we have colleagues at Duke who have replicated the system and have expanded it to Duke. So we'll be analyzing that as well. If you're thinking about potentially taking pieces of this project, some lessons learned along the way. So as you probably saw from some of the results, the best practice advisory, it may not be as effective as embedding the screening tool in the workflow of your note template. You could see there were many that were dismissed and ultimately did not get enrolled. Again, I mentioned it only popped up once, and so potential other things that could be changed are to have it pop up again for the MA at a different part of this, the second time they open the chart, because many we heard during the interviews that they opened the chart when they were reviewing the chart when they were outside of the patient's room, so they didn't have the opportunity to ask that question in front of the patient. So they hit dismissed. By the time they got back into the room, it didn't pop up again, so they didn't have the opportunity to re-ask. So potentially adding it as a second pop-up, or if the MA does not ask, having it go to the provider to ask. But we heard feedback from many of our meetings that providers really, really did not want a BPA. So thinking about that. Again, I think some buy-in. We did do training, as I mentioned, of all of our providers, but it was really just a one-time training. And we really found that there was a little bit of resistance to some of this screening, particularly from our MAs. So really getting some buy-in from them, doing some more education, I think would be helpful. We also heard in our interviews that many of the providers, both WIC and healthcare providers, were not familiar with that in-basket communication, so they didn't know that we could communicate with each other. So I think more education about that is really important, because if you have a question, you can really just send it quickly through the EHR. And then I think it's important to really better understand families' perceptions of why they were potentially uncomfortable with that sharing of information across agencies. And so I think qualitative exploration may be helpful for that. So I got to bring in some policy here for potential advocacy. So I mentioned the waivers early on in the presentation. So those have all expired. However, there are now, the USDA has provided states with the option to continue 2 of those waivers, the physical presence waiver and the remote benefits issuance. I know just my state, because I know that data, but we did expand. I tried to look on California's website and I couldn't tell, and I don't know if any of you know whether California has adopted those, but if not, that would be a potential avenue of advocacy to get those, continue those waivers, because they've been, studies have shown they've been very helpful for increasing enrollment in WIC. The House Appropriations proposal for 2024 included a provision to cut WIC funding for lower than the 2023 level, so by $185 million. That would have meant cutting fruit and vegetable benefits to children by 56% and for adults by 70%. Luckily, there was a continuing resolution passed, and so funding was maintained at 2023 levels through November 17th. But as you can imagine, that may be threatened again, and so that's another opportunity for advocacy for WIC. And then I mentioned this sort of data sharing, this cross-sharing of data. If you've ever tried to obtain data from WIC, it is a very tedious and arduous process with lots of administrative barriers. So I think to be able to share data would be ideal, and that would require some sort of policy and data infrastructure innovations. So opportunities, again, for advocacy. A little under time here. So I have a huge team of people who have helped, from study staff to medical students to residents to the EPIC team to funding, our CTSI, our qualitative research team, and then our WIC team has just been absolutely amazing throughout all of this with our work. So thank you for listening, and I'd be happy to answer any questions.
Take any questions in the room. I know there are a few questions online as well.
Dr. Montez, excellent presentation. So one of the issues, I think, for particularly immigrant populations is understanding and sort of working through all the different agencies. Where do you think social media could help in that area? It really, it's blossomed. And the question is, how are we as physicians and healthcare providers going to reach out on that area?
Yeah, I think that's a great question. I think certainly that's one avenue. I think even just really it starts in the clinic. And so I don't know if you are screening for WIC, but I think that powerful relationship that you have with your patient, even just discussing with WIC, hearing that from you is important. And so I think it starts there. You recommending WIC and telling them why it's beneficial, I think is helpful for any patient, but particularly for our undocumented patients, because it is one of the only federal nutrition programs that is available regardless of immigration status. And so that is really important so that it can improve health equity. I think other avenues such as WIC recommendations, social media, education by peers. I think there are some peer programs that have been really helpful as well. And so I think each of those avenues are really helpful. If you are on social media, certainly I think that's a great way to sort of reach a larger audience. But I think, that trusted relationship that patients have with us is going to be the most powerful.
Thank you so much for your work and advocacy in this area. I was wondering if you could speak to any work you know about going on around quality of food in WIC, because I know there's been some research locally, and just access to food programs don't always have the highest quality of food, which is unfortunate given that our patients need not just access to food, but high quality food.
Right. Yeah. I could say that there were expansion of the fruit and vegetable benefit, which has been studies have shown have been very beneficial, which is why that I think appropriations was really important, because I think that is the highest quality. I think nutrition standards need sort of updating, and hopefully with this farm bill, that's going to be a piece of that again is sort of off the radar right now just because of everything that's going on in Congress, but I think will be important to kind of think of because that's where the child nutrition programs come into play. And so I think that's another avenue for advocacy is those standards, those nutrition standards for all of the programs, not just WIC, but also the school programs and things like that. So yes, I agree that is very important.
Thanks so much for that really great talk. And I was really struck by the amount of bureaucratic oversight that is really needed for these families to navigate. And that's very analogous to in peds endocrine, and there's a lot of bureaucracy to try to get, for example, sensors and diabetes technology covered. So one of the efforts locally has been to try to get that paperwork and that bureaucratic stuff to go down. So I actually have a very fundamental question, which is there a way for a family to self-refer in, or have you talked about how to cut that prescription being done just the right way so that it can almost just be a single click, or is there a problem on the other end in the number of referrals they may get and streaming? So I was just wondering if you could.
Yeah, it's a good question. So I thought it was a great thing that we put the prescription in the chart, because it was exactly what WIC was asking for and it eliminated. But then we heard from providers that there are just way too many clicks. And so I think it's a challenge to be able to get WIC what they want but also not having to do so much information from the healthcare standpoint. That I'm aware of for prescription purposes, which is that has to come from a healthcare provider, but patients can self-refer. And I was looking at California as well. I mean, there are online, like for North Carolina, there's this easy online referral that anybody can refer. So even we as providers could refer, families could self-refer, and WIC is required to contact that family within 30 days. I think California has a similar referral form that I was looking up. I don't know that it's online, but you can at least print it. And if you could similarly use that in your chart, but I think families can self-refer. It does require some information like height and weight and things like that. But I think families can self-refer. But the prescription does need to come from a healthcare provider. So that part is a little bit tedious. If anyone wants to add, yeah, please.
Thanks. So thanks, Dr. Walraven. She was highlighting there's a QR code that can be scanned that our lactation consultant shared.
That's great. That's lovely.
Dr. Montez, since you work closely with the AAP, can you tell us what kind of activities they're planning to do in this area, particularly with the political situation of our country? How do we as pediatricians help AAP?
Yeah, great question. So the White House had its first ever conference on hunger and health, which the AAP was part of. And from that, they secured millions of dollars in commitments from many different companies, from healthcare provider companies, professional organizations, to technology companies to really commit to this effort, and the AAP is one of them. So AAP is partnering with Share Our Strength to educate all of pediatricians about food insecurity and the federal nutrition programs. They also have chapters that they funded across the country for providers to work on, and they're actually, some of them are working on projects just like this. And so I've been able to talk through some of the work that we've done, but people are replicating these. So I think if it's something that you want to be a part of, you could certainly join. We have at the NCE, we're doing a food insecurity course, which is the first time we've ever done that as well. So if you're at NCE, that's something you can attend. But if you're interested in getting involved, they're always having new cohorts. And so that's one way that you can get involved. Because of that White House commitment, AAP has been very committed to food insecurity, but also early childhood enrollment in WIC and SNAP.
There's a fundamental question here on online that I noticed patients who participated in WIC, there are still about a quarter who reported food insecurity. Any further information on this? Does WIC acceptance not fully accomplish the elimination of food insecurity?
Yeah, unfortunately, it's a supplemental program, and the same is true for SNAP. And so it's not meant, the design of the program isn't meant to fully meet the need of families. And many studies have shown that unfortunately it doesn't. So yes, many families do still report food insecurity despite having WIC benefits, because sometimes they may not meet the family's need. SNAP, especially for undocumented immigrants, if you have an undocumented parent and you're a citizen child, that kind of lowers your amount that you're able to get. So that's another avenue for advocacy. But I think increasing the benefit amount is always ideal. But again, as you mentioned, Dr. Mendoza, I think during the current climate, that will be potentially difficult to do. But I think it's always important to advocate for that, because benefits, unfortunately, studies have shown, run out by the end of the month. So.
A couple other questions online. Thank you so much for your excellent work. Could you talk a little bit about remote connectivity and vulnerable populations? How are WIC and/or pediatric homes meeting digital native patients where they are?
Yeah, that's a great question. I think the digital divide and greenlining is a very big concern. I know that the USDA is putting a lot of funds into innovation, and the technology is one of them. I don't know the details of what that looks like, but I know it is an area of focus for them. So they're really interested in innovating that technology, and I think that includes reaching those families may not otherwise have access. They're also really focused on diversifying their workforce, and so that's another area that they've made a commitment towards. And so I don't know the details of like what that looks like, but I know that it is an important a goal that they have to work on.
A follow-up question is in your opinion, what's the major barrier to the efficient communication among stakeholders? So in other words, why are we still faxing?
That's a really great question. Well, I think we can leverage the EHR more than we do. I think it's just being aware, I think, of some of these things that may be available, or having the wherewithal to do it. And working with your IT partners is super important. Becoming an Epic builder has also been we've had members of our team who are Epic builders. That's been really important. So I think it's leveraging what we have to be able to cross communicate. And I don't know that faxing will, I hope it does go away. But yeah, I think, and those administrative barriers between sharing information. I think you were talking last night about kind of the ACO, like having everyone under an ACO and being able to through that. So I think there are solutions. It's just a matter of adopting them, which are a little slow to do sometimes.
And then a couple of other questions. Why do you think eligible parents, turn down support for their children?
Yeah, I think one of the slides sort of highlighted what some of those are. I think some people think they just don't need it. I think some people, for them, there are barriers to actually accessing it. I think the other is we've heard, not in our survey here, but we've heard that people don't want to take benefits away from those that they feel like may need it more than they do. And so we didn't ask that question specifically, which is where I think qualitative work would kind of maybe unveil some of that. But I think a lack of awareness as well, which again is where we come into. If we can do some education, I think that's important too. So I think it's a variety of barriers that have been pretty well studied, and I know WIC is looking into those barriers. But I do think that we as healthcare providers can eliminate some of those barriers in terms of knowledge. Is one of the big ones. I don't know that we can help with access through making those referrals, but then ultimately we may not be able to help with transportation and things like that. But
and then as you expand across county lines, did you have to reinvent MOUs and processes with new counties?
Yes. Yeah, it's a process everywhere. Some already have them in place, and it was not a problem because they've been working with them. And actually the Charlotte group that we were talking about had already given their WIC providers EHR access. It was just a matter of setting up the referral mechanism. So WIC was able to already access, so that was eliminated. And it was just setting up the referral process and the workflow. But Duke, our colleagues at Duke had this extensive process that they had to go through to get that data sharing agreement. And Duke, instead of giving total access to the patient chart, they only gave them access to a few things like the growth chart, the in-basket, things like that. And so you're able to really decide what access you want to give them. So it is extensive depending on your current relationship with WIC.
And then do the WIC clinics involved in your program serve multiple healthcare systems or clinic, i.e. Separate EHR instances? And how could this impact the sustainability or dissemination of your program?
Yeah, there is another health system in our area that we don't interface with, so they certainly could serve other clinics. So that's potentially a collaboration. I don't know that it'll affect the dissemination or our project specifically. I just think it may limit access for those patients who are part of another healthcare system. But yeah, our WIC partners are very excited about this work. And so if you meet with your WIC providers, I'm sure ours have been lovely. So I'm sure yours are too.
Thank you so much for sharing this
for the
wonderful
opportunity and for your time and attention. It's been a pleasure.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.